Welcome to the Deep Dive. We're here to give you those critical insights you need, sharpening your understanding for the postgraduate exit exams. Today, it's all about acetabular and sacral fractures. Really vital stuff, not just for exams, but, for day-to-day clinical practice too. And our guide for this, it's the excellent author-made simple notes you can find over at mokyingren.sg. These were put together by Dr. Mok Ying Ren, who's a sports surgeon at National University Hospital in Singapore. He nailed his own FRCS back in 2022, so he definitely knows what's needed.
Absolutely. And these fractures, acetabular and sacral, they're, well, they're challenging for a reason. You've got complex anatomy, the real risk of some pretty severe complications, and you absolutely need precise classification and management plans. That's why they're such high-yield topics for exams. They really force you to connect the theory to practical decision-making.
Okay, let's dive straight into acetabular fractures then. When you first see a patient, apart from the obvious fracture, what immediate soft tissue issues should be right at the top of your mind? Anything often missed?
That's a great starting point. A really key one, sometimes overlooked but critical, is the Morel-Lavallée lesion. Essentially, it's a closed degloving injury. The subcutaneous tissue gets sheared off the fascia underneath, creates a potential space, fills with fluid, blood, maybe some necrotic fat, and that's a big setup for infection risk, poor wound healing later on. Very common with the kind of high-energy trauma that causes these fractures.
Morel-Lavallée, got it. And what about nerves and vessels? Always a concern in the pelvis.
Definitely. You've got to be thinking about the superior gluteal neurovascular bundle. It's particularly vulnerable. It pops out of the pelvis through the greater sciatic notch, you see. So a fracture right there. It can easily tether it, compress it, or, well, worse. Big implications for gluteal muscle function if it gets damaged.
Okay, so soft tissues, neurovascular checks done. Now the bone itself, classification seems absolutely key here for residents trying to manage these. What's the cornerstone system we need to master?
Yeah, you really need a framework. And without a doubt, the Judet-Letournel classification is that bedrock system. It's the language everyone uses. It basically splits acetabular fractures into two big groups.
Yeah.
The 5 elementary types and the 5 associated types.
Right. Elementary and associated. Let's break down the elementary ones first.
Okay, the 5 elementary fractures are posterior wall only, anterior wall, posterior column, and transverse. And it's worth remembering, posterior wall only, that's the most common elementary one you'll see. Oh, and a key point about transverse, it means both columns are disrupted, the anterior and posterior. But crucially, there are no other fracture lines involving the articular surface itself. Just that single transverse break across the columns.
Got it. Both columns broken, nothing else
Yeah.
particular. Okay, what about the associated patterns? They sound more complex.
They are combinations, yeah. So the 5 associated fractures. First, you've got transverse plus posterior wall. See that in about 20% of cases. It means both column lines are disrupted, like a transverse, but the obturator ring is intact, and you've also got that posterior wall piece broken off.
Okay, transverse plus PW, 20%. Next.
Next, associated by columnar, or ABC, about 22% of cases, so quite common too. This one's critical to get right. It's basically a transverse fracture plus an iliac wing fracture and an obturator ring fracture. And the really diagnostic thing you look for, almost pathognomonic, is the spur sign on the obturator oblique view. We'll come back to that. But the defining feature of an ABC is this.
Yeah.
No part of the articular surface remains attached to the axial skeleton. Everything's disconnected.
Wow, okay. Complete detachment. What else in the associated group?
Then there's anterior column plus posterior hemitransverse. You often see this pattern classically in older patients with osteoporotic acetabular fracture.
Osteoporotic pattern, right.
Then the T-type. Think of it like a transverse fracture, but it only involves an additional break through the obturator ring. Transverse plus obturator ring, #only.
Okay, T-type. And the last one.
Last one is posterior wall plus posterior column. So combination of those two specific posterior structures.
That's a really detailed breakdown, thanks. So if you're in an exam, pressure's on. What are the top 3 most common patterns overall that you absolutely need to have locked in?
Good question for rapid recall. The big 3 you really need to know cold are posterior wall only, the most common elementary, associated by columnar or ABC, and transverse plus posterior wall. Get those down, and you've covered a huge chunk of acetabular fractures.
Perfect. PW only, ABC, transverse plus PW. Right, let's shift to imaging. X-rays first, obviously. When you're looking at that initial AP pelvis, what are the absolute must-identify lines?
Yeah, a systematic approach here is vital. You have to trace out several key lines on every film. You need the iliopectineal line that outlines your anterior column, then the ilioscule line, that's your posterior column indicator, Beyond those two main ones, you assess the roof, the radiographic teardrop, the anterior wall line, the posterior wall line. And always, always check Shenton's line for any break suggesting hip subluxation or dislocation. Any disruption in these lines is your clue to a fracture and helps start the classification process.
Okay, so systematically checking those lines on the AP. But we always get those special oblique views, too, the Judette views. What exactly are they showing us?
Ah, yes, the Judette views can't manage acetabular fractures without them. You have the iliac oblique view, sometimes called PCO.
PCO.
Yep, PICO. Stands for posterior column iliac oblique view. It's designed to give you the best look at the posterior column and the anterior wall.
Okay, IO shows posterior column, anterior wall. What about the other one?
The other is the obturator oblique view, and that one profiles the anterior column and the posterior wall. So you use them together. One view shows you two structures well, the other shows the other two. Helps you build that 3D picture in your head.
Makes sense. And are there specific radiographic signs on these views we should be hunting for? You mentioned the spur sign earlier.
Exactly. There are definitely specific signs. The spur sign is probably the most crucial one to recognize. You see it on the obturator oblique view. It looks like a spike or spur of bone. It's actually the most caudal or lowest part of the intact ilium sticking out. It appears because the articular parts of the acetabulum have shifted medially away from that stable part of the ilium. And the reason it's so important, why it's pathognomonic for an associated bicolumnar fracture, is because it signifies that complete separation of the articular surface from the stable ilium. That's the hallmark of an ABC.
Ah, okay. So the spur sign equals complete separation equals ABC fracture. Got it. Any other signs?
Another one to look for is the gull sign. It looks like a seagull in profile on the radiograph, and it indicates an impaction fracture of the supramedial dome of the acetabulum. Important for prognosis.
Gull sign for dome impaction. Okay, so we've milked the plain films and Judith views. What does the CT scan add? Why is it so essential?
Oh, CT is non-negotiable. It gives you that crucial third dimension, much better detail of the fracture anatomy. What you're really zoning in on with CT, beyond just confirming the pattern, are things like marginal impaction. And honestly, this might be the single most important finding on the CT. You're also looking for intra-articular fragments, loose bits of bone or cartilage in the joint, and assessing the overall fracture comminution, how many pieces it's in.
You emphasize marginal impaction there. Can you elaborate on that? What exactly is it, and why is it so critical?
Right, marginal impaction. It's an intra-articular fracture, but specifically, it's where the subchondral bone, the dense bone right under the cartilage, gets crushed and often flipped up, kind of perpendicular to the femoral head surface. Think about it. The smooth cartilage surface and its supporting bone are now disrupted, uneven. That's a direct pathway to joint surface damage and almost certainly future post-traumatic osteoarthritis if it's not addressed. It's particularly common. You see it very often with posterior wall fractures, actually. Sometimes the x-rays can look okay-ish, but the CT reveals this significant impaction, and that totally changes your management plan towards surgery. It's subtle, but game-changing.
Okay, so that detailed CT info is key. How does all this diagnostic workup translate into actual management decisions? What are the general principles for definitive treatment?
Right, the decision-making. It's never just one factor. Definitive treatment always balances patient factors against injury factors. Patient factors are things like, their age, overall health, comorbidities, can they tolerate a big operation? And then the injury factors, we often use a simple mnemonic for those, CSW.
CSW, okay, useful. What does that stand for, and how do those factors guide treatment, especially maybe in those borderline cases?
Okay, CSW stands for congruency, stability, and weight-bearing area.
Congruency, stability, weight-bearing area.
First, congruency. Is the hip joint congruent? Is the ball sitting smoothly in the socket? We know from lots of studies that if you leave a step off in the joint surface greater than 2 millimeters after reduction, the risk of developing significant arthritis later is much, much higher. So achieving anatomical congruency is a major goal.
Okay, 2 millimeter step means high OA risk. What about S?
S is stability. Is the hip joint stable through a range of motion? This is particularly critical for certain fractures like posterior wall fragments. An unstable hip usually needs fixing.
And WOP, weight-bearing area.
W is weight-bearing area. This refers to the dome, the roof of the acetabulum, the part that takes most of the load during walking. We assess its integrity using roof arc angles, which Matta and colleagues described. On x-rays, the original Matta angles gave specific degree cutoffs on the different views, like medial 30 degrees, anterior 40 degrees on the obturator oblique, posterior 50 degrees on the iliac oblique. Fractures extending beyond these angles involve less critical, non-weight-bearing bone.
Right, those specific angles.
And on CT, there's a simpler rule of thumb. You look at the axial cuts. If the fracture involves the area within 10 millimeters down from the very top, the vertex of the acetabulum, that generally corresponds to involving the critical 45-degree weight-bearing arc. So if the fracture significantly disrupts this dome, this main weight-bearing area, that pushes you strongly towards surgery to restore it.
That CSW framework is really helpful. Let's apply it. How about isolated posterior wall fractures? You mentioned stability is key there. How do we actually assess that?
Exactly. For isolated posterior wall fractures, treatment really hinges on stability. Now, how to assess it? There are a few ways described. Some people use size cutoffs based on the percentage of the wall involved. You can see figures like 20%, 40%, maybe 50% used as a rough guide. Larger fragments are more likely to be unstable.
Size guides. Okay. But you mentioned a dynamic assessment.
Yes, and arguably a more definitive way is dynamic assessment under anesthesia, often called dynamic stress views, which Dr. Frank Tornetta really championed. This is done in the operating room under GA using fluoroscopy, so live X-ray. The surgeon carefully moves the hip through specific ranges, internal-external rotation, extension, abduction, sometimes even applying a bit of force, like gently rocking the patient. And you watch the screen intently to see if the femoral head subluxates or loses congruence with the acetabulum during these movements. If it does become unstable under stress, that's your indication for surgical fixation.
That sounds like a really thorough way to check stability directly. Okay, let's switch gears to another challenging one. Associated bicolumnar, the ABC fractures. I've heard this term secondary congruence thrown around, sometimes suggesting non-operative treatment might be okay. What's that about?
Ah, yes, secondary congruence. It's an interesting and somewhat controversial concept that Letournel originally described specifically for ABC fractures. The idea was that because all the articular fragments are detached from the stable ilium in an ABC fracture, the whole articular surface might sort of float and potentially reorient itself around the femoral head. So it wouldn't be anatomically reduced, but it might achieve a kind of secondary non-anatomical congruence. And the thinking was maybe this could lead to acceptable results without surgery.
An extra anatomical fit. But does that hold up now? What's the current thinking?
Well, that's where it gets interesting. While the concept exists, our biomechanical understanding has moved on. Studies, like those by Levine and others, have looked at this biomechanically. They found that even in cases with apparent secondary congruence managed non-operatively, the peak contact pressures in the acetabular roof, that critical weight-bearing area, were often significantly increased compared to anatomical reduction.
Some higher pressure even if it looks congruent.
Exactly. And persistently higher pressure raises the concern, the potential risk, of developing secondary osteoarthritis later on. So the bottom line now, while you need to know the principle of secondary congruence, the general tendency, if the patient is medically fit for surgery, is definitely to offer ORAF. Aim for anatomical reduction to restore normal biomechanics and hopefully give the best long-term outcome, rather than relying on this theoretical secondary fit. It's a good example of how evidence evolves practice.
Makes sense. Prioritize anatomical reduction if possible. So if we are doing surgery, what are the typical approaches?
Surgical approaches are tailored to the fracture pattern, of course. For anterior access, dealing with anterior column, anterior wall, maybe quadrilateral plate fractures, you have options like the ilioinguinal approach or modifications like the STAPA or AIP. For posterior access, posterior wall, posterior column, the Kusher-Langenbeck approach is the workhorse. And sometimes, for better joint visualization, you might add a trochanteric flip osteotomy.
Okay. And any specific danger zones anatomically during these approaches? I remember hearing about the corona mortis.
Ah, yes, the crown of death. Sounds dramatic, but it's a really important anatomical point, especially with anterior approaches like the ilioinguinal or STAPA. It refers to a potential vascular connection, an anastomosis, that can run right behind the superior pubic ramus. It's usually between branches of the external iliac system, like the inferior epigastric, and the internal iliac system, specifically the obturator vessels. It can be an artery, a vein, or both, and it's quite variable. The danger is, if you're dissecting near the pubic ramus and you don't identify and control it, injuring it can cause really significant, hard-to-control bleeding. So meticulous dissection there is crucial.
Good reminder. Corona mortis equals vessel anastomosis behind superior pubic ramus. And fixation. What hardware do we typically use?
Fixation usually involves specialized implants. Things like long screws placed along the columns for stability, and often malleable reconstruction plates, usually 3.5 millimeters, that you can contour precisely to the pelvic bone shape to buttress the reduction.
Right. Now, thinking long term for some of these really bad fractures, maybe in older patients or those not fit for that big initial ORAF, what's the plan B? Can you convert these to a hip replacement later?
Absolutely. For patients who weren't ideal candidates for complex fixation up front, or maybe those whose initial fixation fails or develops painful arthritis, a delayed total hip replacement, or THR, is a very good salvage option.
How do you handle existing plates or screws during that conversion?
That's a key consideration. If there's retained hardware from the fracture surgery, you have to plan for it. Often, you'll need to identify any screws that might interfere with the THR components. You might need to cut them flush with the bone, maybe burr them down smoothly so they don't impinge. If there's significant bone loss from the original injury, you might need techniques like impaction bone grafting to rebuild the acetabular socket before putting in the cup. Often, a cemented socket is used in these cases to get better initial stability in potentially compromised bone. It's definitely a more complex THR than a standard primary one.
Complex, but a vital option. Okay, let's pivot now to the foundation of the pelvis sacral fractures. Sometimes overshadowed by acetabular trauma, but equally important. How do we classify these?
Yes, definitely shouldn't overlook sacral fractures. They're critical for pelvic stability and, crucially, nerve function. The most widely used classification is the Dennis classification. It's based purely on the fracture line's relationship to the sacral foramina, those holes where the nerve roots exit. Dennis type 1 is lateral to the foramina, most common, about 50% of cases. Relatively low risk of nerve injury, around 6%. Type 2 goes through the foramina. Nerve injury risk jumps significantly here, up to about 28%. And type 3 is medial to the foramina, crossing the central sacral canal. This carries the highest risk, about 57% chance of nerve injury, often including bowel bladder dysfunction. So you see this clear progression. The more medial the fracture, the higher the nerve injury risk.
That progression is easy to remember. Lateral through medial increasing nerve risk. Got it. Any other ways to classify them?
There are also classifications based on the fracture shape or pattern, which often relate to the mechanism and stability. You hear terms like transverse sacral fractures, spinopelvic dissociation, which is a transverse fracture leading to instability between spine and pelvis, and complex patterns like H-shape or U-shape fractures, often associated with high-energy pelvic ring injuries.
Okay. And management. When you treat conservatively versus operatively, and if you are operating, say, putting in SIJ screws, what are the absolute key safety points?
Management generally follows displacement. If it's essentially undisplaced, defined usually as less than 1 centimeters of displacement, conservative management is often the way to go. Pain control, protected weight bearing, gradual mobilization. But if it's significantly displaced, say more than 1 centimeter, then ORAF, open reduction internal fixation, is usually recommended. The goals are to restore the stability of the pelvic ring and, if necessary, decompress any compromised nerve roots.
And the surgical safety for screw placement. Nerves are right there.
Absolutely paramount. When you're placing sacroiliac joint screws or screws into the sacrum itself, you are working very close to the S1 and particularly the L5 nerve roots. Injury is a real risk. Safe placement relies heavily on meticulous use of fluoroscopy and understanding the landmarks on different views. On the lateral view, you need to ensure the iliac cortical densities, the ICDs, are perfectly superimposed. This line essentially marks the safe anterosuperior boundary of the S1 body. Going anterior or superior to this risks hitting the L5 nerve root as it crosses the sacral ala.
Okay, lateral view for the L5 boundary using ICDs. What about the other views?
The outlet view is your guide for superior-inferior positioning. It opens up the view of the sacral forma, helping you ensure your screw trajectory is safely within the bony corridor of S1 or S2, away from the nerve roots exiting the foramina below. And the inlet view is crucial for judging anterior or posterior depth. It clearly shows the S1 body in cross-section, allowing you to aim for the center and confirm your screw isn't breaching anteriorly towards vessels or posteriorly into the canal. Using all three views systematically is key to safe fixation.
That's incredibly practical advice. We've certainly covered a huge amount today, from the nuances of acetabular classifications, those critical radiographic signs like the spur and gull signs, the importance of CT for marginal impaction, right through to management strategies like CSW, dynamic stability testing, the whole secondary congruence debate for ABCs, and then shifting to sacral fractures, their classification, and crucially, the safe surgical corridors. Mastering all this is just fundamental, isn't it? For exam success, yes, but much more importantly, for getting the best outcomes for our patients with these really tough injuries. And just a reminder, this deep dive drew heavily from the Ortho Made Simple notes over at mokyingren.sg.
It really did. And thinking about all this, perhaps it leaves you, the listener, with a final thought to chew on. How does this constantly evolving understanding we have, especially around biomechanics like we discussed with secondary congruence, how does that push us to continually question and reevaluate even principles we thought were set in stone in trauma care? And looking forward, what do you think the next big leap will be? What technologies or maybe biological insights are on the horizon that could really change the game for improving outcomes after these complex pelvic and acetabular injuries? Something to keep thinking about.
A really great question to end on. Keep digging, keep learning. Thanks so much for joining us on this deep dive. Stay curious, and we'll catch you on the next one.